And I was trying to figure out, how do I extend my durability? And in that process, I ran across issues of metabolic health as being an underlying contributing cause. And when I started to do that analysis, I realized that 99% of my patients were metabolically ill. And I thought, well, that's odd. It doesn't make any sense. I didn't realize that. So as I did a little bit more research, came to the conclusion that it used to be in the 1930s and 1940s, about 20-30% of our population was metabolically ill, 70% was healthy. And as we progressed into the late 70s, 80s, the metabolic illness rate really dramatically climbed. And by the mid 80s, I would say almost 80% of the population was metabolically sick and 20% was metabolically healthy. And by the 90s, 83% of the population was metabolically ill. And then at post-COVID, or right before COVID, it was a little bit less. And then post-COVID, it was 93%. So 7% of our population is healthy, 93% sick. Of those that seek medical care, though, patients with pain, patients with nerve, patients that are obese, patients with high blood pressure, patients with thyroid dysfunction, patients with sleep issues, patients with anxiety, patients with depression, patients with cancers, any of those symptoms, those patients all have metabolic issues underlying. And in fact, such to the point where schizophrenia is really a metabolic issue. 75% of patients, once you fix their metabolism, stop hearing voices. I know that you guys already know this stuff, but it's interesting when you look at it from that side, instead of looking at it from, I got to treat this patient's symptom, to, even if I treat the patient's symptom, will they get permanently better? And what do I do to make them permanently better long term? When we're doing regenerative medicine, we're restoring metabolic health. The underlying basis of this, you'll see a slide, I'm hoping that you'll see this PDF that talks about life expectancy and health-adjusted life expectancy. Do you see that on the screen? Okay, so historically, we look at, you're born, you have peak life forces, and you die. Our goal has been to increase health span. But from the metrics that the federal government looks at this from, and from an econometric standpoint, they're looking at area under the curve. And when you become senescent, you're born, and it takes healthcare resources and generalized economic resources to get you to the point where you're functional and a standalone individual. Somewhere up here, you're highly productive and you're making a lot of revenue. And then as you die, this area under the curve hopefully is less than the area under the curve when you were productive. Because if it's not, we have a skewed economy. If this area becomes longer or bigger and this area is shorter, we have a problem. Now, historically, we've looked at increasing health span, so the area under the curve is shorter here. This would be somebody that has a stroke, sits in a nursing home for 10 years and eventually succumbs, and they've used a lot of resources. This would be somebody that dies acutely with an acute injury or an acute issue, suddenly, and they've been perfectly healthy for a long period of time, functional and productive, and then they start to consume resources right at the very end. My goal is to increase health span, but even more than that, increase lifespan and decrease the amount of time in poor health. And if you increase health span, you increase the area under the curve in the green area. And that's the point of what I'm trying to accomplish. And I can do that with metabolic restoration. As physicians, we've got a problem. If you look at actual dollar income, inflation adjusted is down 50% over the last 10 years. So we've lost 50% of our purchasing power over the last 10 years. The cost of inflation adjusted healthcare expenditure, however, has gone up 80% at the same time. So our income, inflation adjusted, is down 50%, but the cost of care delivery is up 80%. What's the issue here? What's going on? Why is this money not ending up in the pockets of the people providing the care? It's because the administrative burden headcount has gone up 3,800%. Certainly there's factors such as increased cost of drugs, increased cost of everything else, labor supply and everything else. But really the primary thing is here, because for every one physician that we now have 10 administrators. And this is a novel thing. Physician growth rate is in line with population growth rate, but currently there's 10 hospital administrators for every physician. And that really propped up in the late 90s, mid 90s to late 90s, and just started to shoot up. And it's actually getting worse in the mid 2020s. We're actually seeing that number will probably continue to rise, and the physician number is basically the same. We're certainly getting some ancillary providers coming in, nurse practitioners and physician assistants and things like that. But even there, the global number of providers is pretty stable. It's not dramatically going up, but the administrative burden is going up dramatically. We know that underlying all of this, the issues with metabolism, is this concept of obesity. And we know that when you have underlying obesity, or you have underlying insulin resistance, or you have underlying other issues, you get metabolic dysfunction. Such to the point that it is the obesity and the insulin resistance that is driving a lot of our disease processes that we treat in interventional pain, but also are treated in the rest of medicine. Now, I said that 93% of the general population is metabolically ill, 99% of our population is metabolically ill. It becomes very evident when you start looking at subpopulations, and it becomes real evident. But the underlying issue is insulin resistance, and there's a whole host of factors that lead to insulin resistance. But the problem is that we're not recognizing them. We're still measuring things like hemoglobin A1C to determine insulin resistance. And the reality is hemoglobin A1C goes down as insulin levels go up before hemoglobin A1C goes up as insulin levels go down. So what's happening is that when you first start to have excessive fat accumulation, when you first start to become insulin resistant in the cells, your pancreas dumps extra insulin. Well, insulin itself is a growth factor, and it's a triggering agent, and converts a lot of our macrophages and converts our system into increasing risk for angiogenesis, increasing risk for fibrosis, increasing risk, eventually increasing leptin, and leptin independently is a potent cytokine. So there's a whole host of things that get activated that cause massive complications related just to the insulin itself. So those are the kind of things that I'm looking at and have been trying to figure out how to elucidate and how to solve to improve my outcome. And it didn't hit me until I realized that, yeah, we're struggling with this in pain management, but you know who's really struggling with this and who's the tip of the spear for this is orthopedic surgery. And certainly we are when we do orthobiologics, when we're doing PRP and bone marrow, and when we're doing that kind of stuff. But who's at the tip of the spear is the orthopedic surgeon. And they are the ones that we think of them as, we think of them as Uggs that go off and fix broken bones. But they're at the tip of the spear, and they're seeing this in a way that we don't see it. And to give you an example, we can identify 8 years before the patient has arthritic change in their knee, 8 years before they have arthritic change in their hip, which hip is going to be bad based upon intra-articular inflammatory markers that are metabolic. Not just general markers, but specifically metabolic markers. And that's 8 years before you get x-ray changes. And we can identify which hip is going to need to be replaced first. Now, why is that relevant? Well, the surgeon gets paid $1,378 for every total hip if they're doing Medicare. And they get $1,430 for every total knee. And there's a 90-day global. That's what they're making. So if they put in the hip or the knee backwards, they got a problem, and they're going to have to deal with that patient for the next 90 days. If the patient gets an infection, even if they're a pig farmer and they fall in muck and they get an infection in the first 90 days, they got to deal with it. They've always been accepting of the fact that, well, it's a 90-day global, we're going to have to deal with it. Except now Medicare has changed this, and they put in some guidelines last year. They kicked in April of 2024, and these are mandatory inpatient THA, TKA guidelines. And it says, hey, we're going to send a questionnaire to these patients day 300 to 360. And we're going to ask them, how are you doing? Are you able to return to full function? Are you still taking narcotics? And these lack granularity. It's not going to ask, and I've seen the brochure, I've got the questionnaires. They're very generic. And they basically ask, are you still taking pain medicine? Have you been able to go back to normal full function that you would expect before your surgery? So they're not granular enough to say, you had your right knee replaced. Does your right knee feel better? Now, why is this important? Because Medicare is going to whack the hospital for 25% of their next year's inflation adjustment for Medicare. So the average hospital is looking at a 25% reduction in global Medicare income. So they're looking at, the average hospital is looking at about $1 million the first year that this rolls out, and that'll be in 2025. So they're measuring for patients that started in 2024 April, and those first set of questionnaires, they've already showed what they're going to look like. They're starting to roll out 300 days after April. So what it'll do is it'll affect the high volume surgeon. And so the surgeons are going to feel this first, and they're recognizing it. The reason why they walk away from so many patients, because per 1,000 patients, they reject 9,000 patients. They screen 9,000 and reject. Per 1,000 that they do, they reject 9,000. Those patients end up with us. Those are the ones that are metabolically injured in the first place. That's how they got to pain management, because a lot of them couldn't have surgery. They're not good candidates for surgery because they're metabolically dysfunctional. Per 1,000 that they operate on, they reject 9,000. So we've got orthopedic surgeons that we're working with. We've implemented our Measura protocol for lifestyle management and health optimization, and they generate an extra 1,050 per patient that they enroll. They keep 60%, we get 40. So that if they have 1,000 patients in their practice, they're generating an extra 844,000 per annum. They're keeping 60% of that. Most of these surgeons are doing 1,000 patients that they operated on, but they're also looking at the 9,000 patients that were metabolically ill that perfectly fit this population that they can tune up, have bound to their practice, and then they can operate on them when they get metabolically healthy. Now, the chance that a patient on their own is going to lose weight is 1 chance in 167. If they follow our protocols, we're 8 out of 10. So we're doing a different approach than they are. We use an approach that is addiction-based rather than eat less and move more. We look at satiety and addiction-based processes. And that's what differentiates it. I'll go over what the exact Measura components are and the valuation, but this crystallizes for you that what we're dealing with is what other practitioners are dealing with. It just so happens that they're going to get hurt before we are, but I guarantee you that Medicare is rolling this out to the ASCs next year, which means that the surgical centers are going to get hit, and then they're going to roll it out and use components of this in other areas. I don't think that we're going to be able to walk around it and say, oh, well, maybe we don't have to do this. Maybe there's another way to do it. Maybe because of the deference to the federal government, it's not what we have to adhere to anymore. Maybe we can get out of it. And I don't think that's the case. I think that we're gonna get stuck because the actual balancing of the budget is a law rather than an interpretation by CMS. So I think that they're going to use that inside the balancing, saying, well, we're going to do a global cut and we're going to base it on quality measures, which are actually law rather than on deference. And so I think that's the Chevron deference is not going to help us in this situation. We've got good articles that document 8.5 years before you see significant radiologic change that we've got metabolic markers. We've got a whole host of markers that we can look at. None of these are really relevant, but it's just to document that, yeah, we can identify this, and the metabolic markers pre-exist the radiologic evidence. And then there's all kinds of other markers, and these are social determinants of health, lower socioeconomic class, pain levels, support networks, smoking, catastrophizing. These are all social as in terms of musculoskeletal outcome, and these are well documented. If you look at not just the fact that the patient's obese, but let's say that they're sarcopenically wasting, which is physiologic reserve, it's the same concept. Frailty and sarcopenic loss is the same exact thing. So it's not just because they're big, it's because they're big in proportion to their muscle mass. And this poses an interesting statement because we're giving patients Ozempic, we're giving them GLPs. Well, the GLP, the first thing it does is it causes the patient to stop eating. They stop eating protein. When they stop eating protein, what's going to end up happening is they're going to lose muscle first. Then they're going to lose fat. And when they lose muscle first and then they lose fat, when you come off of the GLP, they regain the muscle right away, and it takes 6 times longer to regain the same muscle mass. So if it took you a week to lose the muscle, it takes you 6 weeks of working out to regain that muscle. These patients don't do that. And what they have is they have a frailty syndrome or sarcopenic wasting, and muscle mass is the organ of longevity. So what we've actually done is increase the level of senescence by using GLPs. And that's not the right answer or right way to get this. The other problem is that you're a balancing act, because if you took somebody who was diabetic and you put them on a GLP, you substituted insulin for a GLP, Yeah, you may have decreased their sugar. Yeah, you may have made them lose weight, but it costs you almost the same. They're both about $1,200 a month, between $800 and $1,200. And what's worse is when you got done, they were a lot sicker. Insulin is a growth factor, and there may be some value to that growth factor, although it does promote cancer. It does also maintain some degree of muscle mass, whereas GLPs don't. They cause gastroparesis, they change the pH in the stomach, they reduce the absorption of protein and the breakdown of protein distally, and you get complications, and it only worsens the metabolic dysfunction even greater. We're not the only ones that are dealing with this. If you look at primary care, the metabolic disorders pre-exist the hypertension, pre-exist the heart disease, and we've got all kinds of models that show that. What happens if you didn't have an EKG, you didn't have an ultrasound, you didn't have a stethoscope? How would you diagnose your disease? We've got Measura to diagnose metabolic dysfunction because we're highly sensitive, we're highly specific, and we're able to get to the right diagnosis and combine it with the right combination of information to get to an appropriate lifestyle choice for these patients and to help assist them. Keep in mind that if you don't diagnose, you don't know. About 40% of renal failure patients are undiagnosed until there's a catastrophic event. About 75% of patients that are becoming diabetic don't even know they're becoming diabetic. And even if you use the test that we normally talk about, hemoglobin A1C, it underestimates it. The vast number of patients that have issues with plethysmography, with vasodilation, the issues that they're going to have with coronary perfusion, they don't even know they have a defect in nitric oxide. They complain about other things, but they don't realize it. It's the impotence that's one of the biomarkers, but we're not out there measuring their impotence levels where we can actually measure their vasodilatation and come to some conclusions. If you look at psych patients, the average psychiatrist gets paid $118 an hour, $118.38 through their insurance. If they add Measura protocol, they make an extra $1,100 an hour. And this is ancillary service. This is outside their professional time. So a lot of the medications that they use promote metabolic syndrome. And even beyond that, the vast majority of anxiety is gut microbiome driven and it's metabolic. The vast 75% of schizophrenia, like I said, is metabolic. Depression is at least 50% metabolic. PTSD is a gut microbiome issue and it's maintained microbiome and it's metabolic. So there's a whole host of factors. And our field is a hybrid between medicine, surgical procedures, and psychiatry. That's where we're at, where we deal with this very complex mix of stuff, and this is what we see all day long.